ready for the day. So taking time out of your busy schedule to be here. So really, really appreciate that. So this presentation is very focused, and my plan is to just go over the information, and maybe after that have some discussion if you have any questions regarding management of ADHD in your clinical cases or anything that we can talk more about it. So objective for today's presentation is review some of the existing treatments for ADHD, also identify some of the newer ADHD treatments that are upcoming on the market, and also discuss the risk associated with various ADHD treatments such as side effects or things like that. So overview of ADHD, I think this is pretty much all of us are very well aware. It's one of the common neuropsychiatric disorders you see in your clinic. It's for child psychiatrists, bread and butter of our practice. Most of the days we practice clinically. Prevalence is around 5 to 9% in children. Somehow, boys are more diagnosed than girls in children and adolescents, but by the time they reach adulthood, the prevalence between women and men is same, which we don't know the reason for that. That why is it so more so in the younger age group where one gender is diagnosed more, but by the time they reach adulthood, its kind of presentation is similar, prevalence is similar in both the genders. One of the reasons proposed reasons is like maybe we are not doing that good of a job in diagnosing ADHD in girls when they are in younger population, just because of less hyperactivity but more inattention symptoms seen in girls as compared to the boys. Something to keep in mind. Onset is in childhood and often persist into adulthood, but there are cases who get first diagnosed in like young adulthood also. Reason being, I would say that what I have noticed in clinical practice is also some of these kids never get help during the school years, and once they are on their own, go to college or start job, and the job requires more like coordination, and they start noticing the challenges and seek help on their own. So I won't be surprised if somebody getting diagnosed in adulthood also, because of the missed diagnosis in the early years. As per CDC data, Black non-Hispanic children and white non-Hispanic children are diagnosed more often as compared to Hispanic children or Asian non-Hispanic children. And treatment interventions, we know that there are behavioral therapies involved, present for addressing the ADHD symptoms, especially if there are disruptive behaviors associated with ADHD. And we have pharmacotherapy, which is like one of the most effectively treated diagnoses in our population. Their medications do really work for ADHD. And these are some of the comorbidities to keep in mind. Plain ADHD, yeah, we may see cases here and there, but many times we have a lot of comorbidities present in ADHD, which make it even difficult for us to kind of like treat, and the prognosis becomes more limited when we have other disorders present along with ADHD. 64% of the patients have any mental, emotional, and behavioral health disorder, out of which 50%, half of the ADHD kids have behavior or conduct problem. So you may have to think about doing multimodal treatment, including behavior therapy and pharmacotherapy for treatment of ADHD and behavior problems. And then many of these kids have ADHD. 1/3 of them, ADHD kids, have anxiety, and I would say depression also. And then up to 14% have autism spectrum disorder, and also found comorbid with Tourette disorder. So sometimes there could be only one comorbid condition, but there are times when you may have like 2 or 3 comorbid conditions, such as somebody coming with ADHD, have autism spectrum present, along with anxiety also present, along with the Tourette's is also present, and they could have a behavior problems as well. So you can have a mix of 3 or 4 conditions also at a times when you are seeing a ADHD child. So these are some of the overview of treatment modalities that we have present. So this is a national parent survey from 2016 reported on the medication and behavior treatment utilization for children between age 2 to 17 which showed that 77% of the kids were receiving treatment. And what does that treatment entail? Like 30% of them were only medication, 15% were only receiving behavior treatment, and 32% were receiving ADHD treatment with medications and behavior treatment. But we have to keep in mind that 23% of the children with ADHD were receiving neither medication nor behavior treatment and continue to struggle. So this is something for us as pediatric providers to keep in mind, that many times there are going to be patients who are not getting treatment and doing screening on our visits, on annual visits, or even within our own clinic practice, making sure that this diagnosis is not missed, because this diagnosis can eventually lead to many other comorbid conditions that we just discussed. So regarding pharmacotherapy, this is one of the major studies basically in the world of pediatric psychiatry, MTA, which is multimodal treatment study of children with ADHD. Close to like 600 kids were enrolled, somewhere between average age of 7 to 9, and 6 different sites with very limited exclusion criteria. And the 4 arms were made. This study was done like over a decade ago. And then, or even like more than 2 decades. So 4 medication arms were recognized. 4 treatment arms were recognized. One of them only received medication. One of them received psychosocial, which is like our psychotherapies. And then one received a combination of medication and psychosocial, and one worked as community treatment, like basically didn't do any interventions, but they seek whatever they are seeking in the community at the time. And what they found was at 14 months of follow-up, patients on MTA med algorithm, either alone, like either they are taking just medications or just psychotherapy, or in combination, had a superior response for ADHD symptoms. And patients who had received a combo treatment, which is basically medication plus psychosocial treatments, had a superior response for some of the non-ADHD symptoms, which is more like behavioral symptoms. And kids tolerated this medicine very well, which basically one of the landmark studies in the history for treatment of ADHD, that stimulants had a really good response to treatment of ADHD symptoms. And then this was more so for school-age kids. What about the preschoolers? So good news, we had some studies for preschoolers also, because many times we as a providers get very anxious. Should we start a medication who's less than 5-year-old? But the ADHD seems very disruptive. They are doing some psychotherapy. You know what? There are no resources for psychotherapy in the community. What should we do? So we have some data. This is one of the landmark study, PAT study, which is preschool ADHD treatment study. 3 to 5-year age group, 6 sites treated with methylphenidate. And there were different phases of this. Initially enrollment, then they did like 10 weeks of parent training, and then they did again baseline assessment. After that, there was a 1 week of open label safety lead-in where the patients tried just the medication, all of them. And then there was a 5 week of double blind crossover titration with the placebo and medication. After that, there was also 4-week randomized double-blind parallel study between placebo and medications. And then there was a 10-month open-label maintenance trial also was done. And then once the maintenance trial was done, there was also 6-week randomized double-blind placebo discontinuation study. So although you see the number of kids who were enrolled in all these different studies kept going down, but we have a good data based on like this PAT study, and what they saw was that methylphenidate is one of the effective medications to treat ADHD. Usually what the difference is, we utilize lower dosages, like 0.7 plus minus 0.4 mg per kg body weight. For methylphenidate, I keep in mind of 2 mg per kg body weight for my school age and older kids. So you can see that if I am utilizing 2 mg per kg body weight for some of the older middle school or high school kids, for younger kids, especially preschoolers, dose proportionate is like 0.7 plus minus 0.4, coming down to like 1 mg per kg body weight. Slightly lower effect size, like somewhere between 0.4 to 0.8, which is still not that bad, but not like not as good as you would see in some of the older kids. There are some higher rates of side effects. Something to keep in mind that when you give this medicine, you may see emotional reactivity or irritability caused by this medication in younger age group in preschoolers. Appetite loss can happen, sleep difficulties, stomach aches, like if they are taking it like empty stomach, that can happen in older kids also. Some social withdrawal, like the parents may say that they are like blank, or they are like hyper focused on certain things they do. That's like one of the common side effects you can see with the dopaminergic drugs. And then lethargy also. If they are not like getting good sleep at night, you can have difficulties functioning during the daytime as well. And then one of the good news is that that was the one study that was done back in like 2007 or 8 sometime. And we have another study that just came out in I think this one done in 2019. So this is done with the Vyvanse in preschooler children. So the study that was previously I discussed, that was more immediate release medication like IR version of methylphenidate, but this is longer acting Vyvanse in preschool kids. So what they did in this study was 4 to 5 year olds, 44 different sites, randomized trial in which the medication received was lisdexamfetamine, which is Vyvanse, and they received like 10 milligram, 20, 30 milligram, and compared it with the placebo. And the design of the study was, you can see it here, it was a randomized controlled trial. Age is 4 to 5 years, duration is total 6 weeks, and the dosage was 5, 10, 20, 30. So they went up to 30 milligram in preschooler kids in this particular study. And then outcome was measured by ADHD rating scales for the preschool children. And then total sample size was not as big as the previous one, but still decent, 200 patients, and continued up to 6 weeks. And what you see here is p-value of 0.02, which is a significant p-value. Effect size comparable to our methylphenidate study, which was 0.4 to 0.8, and this effect size is 0.4. And CGI response, which is clinical global response, impairment response, basically 42% improvement in patients taking Vyvanse versus 24% in placebo. So adverse effects, as we discussed, decreased appetite, irritability, one of the common side effects. Discontinuation rate was a little bit more than in placebo, but not a huge difference. As you can see, 5.5% in Vyvanse, 4.4% in placebo. And then difficulties in sleep onset and duration, was not affected by Vyvanse overall, which you would imagine just because of the longer acting version of this nature of this medication. So conclusion for this is that fortunately, now we have 2 really good studies that are in the literature present that has showed immediate release and long-acting medication, ADHD medications showing benefit in the preschool children. So what we can base here is that we can utilize ADHD medications in our younger age group also, especially in kids where there is a really disruptive ADHD, kids who are getting kicked out of the daycare because of their behaviors and there is a suspicion for ADHD in there, or they have tried all the interventions but haven't been successful so far. So you can safely prescribe medications, cautiously monitoring them and starting at a very low dose and slowly going up on the dose and making the parents aware of some of the side effects that we discussed.
Dr. Malhi, can you speak to insurance coverage for medications for some children this young, that there may be some, you have to get an override
I have started this medication myself. I have not received any challenges from the insurance company, even if I have to do prior auth, which I have not done prior auth so far for any of these younger kids. So I'm assuming it's well covered. And we have some literature also behind to back up. And I mentioned these studies. You can utilize these studies as way to kind of present your case to insurance companies as well. But overall, I haven't received any pushback from insurance company for this medication. So one thing that I would say is that when the parents go to pharmacy, sometimes the pharmacist give all this information, which can be overwhelming for the parents. And I have to do a re-education session again with the parent, making sure that the decision that we made is the decision in the right direction. So that's something I have encountered more frequently as compared to any pushback from the parents. But I understand the pharmacy staff also do their best. But I think sometimes there is certainly an anticipation, or like there is some anxiety among people that maybe we should not be utilizing these medication in younger population. But when we make this decision to use medications in younger population, it's definitely when their functional life is affected to the point that they cannot sustain in certain settings. It's affecting the full functioning of the family life. Parents cannot sustain the job because they are constantly taking off from the work to pick up kid, or the kids is like getting kicked from the daycare or can't sustain in the school for a long period of time. So I'm sure that when we make these decisions, it's definitely in those situations. So then, so moving on, those were some of the things that recently came out as I discussed the Wyman study in 2019. So let's talk a little bit about the pharmacotherapy of the medications that we have available right now. And as we all of us probably know, there are two main salts that we use, either methylphenidate salt or amphetamine salt. Methylphenidate salts could be immediate release or could be extended release. And if you talk about methylphenidate salts, immediate release, they are like 30 to 45 minutes onset of action. Mean duration is 3 to 4 hours. And for longer acting, it can go up to 12 hours. And usually the racemic formulations of methylphenidate is D and L enantiomers. And this medication is metabolized by CES1 gene, which basically, if there is a genetic component where CES1 gene is affected, it can affect the pharmacokinetic of the drug. Which basically means that you may not see the same efficacy in some patients with methylphenidate. But do we have any ways to find out which patient has CS1 gene mutation? Not really at this point. So, but something to keep in mind that this could be one of the reasons why methylphenidate salts probably may not be well tolerated or may have more side effects if the gene that's responsible for metabolism of this drug is impacted by one reason or the other. And second one is amphetamine, which is immediate release and extended release. Again, when you give immediate release, between half an hour to 45 minutes, it starts working. Mean duration could be 4 to 6 hours. And for ER formulations, 8 to 12 hours. Something to keep in mind that amphetamine salts are a little bit more potent than methylphenidate salts, and the recommendation is generally suggest doses like roughly half to 2/3 of the methylphenidate. But that being said, there is no data that can tell us head-to-head difference between, okay, if somebody's taking methylphenidate, this many milligram, if somebody's on like 60 milligram of methylphenidate, you know what, I'm just going to start you direct on 20 milligram of Adderall. I won't recommend that because sometimes the metabolism could be very different for different salts. Like amphetamine salts is basically metabolized by cytochrome 2D6. If there is a genetic mutation which affects the metabolism of 2D6, you may have a very varied response with amphetamine. Suppose if it's a slow metabolizer, it means that you probably going to need lesser dosage because the patient is a slow metabolizer. If you put a higher dose, you may have like more side effects because the concentration of the medicine would be higher. Compared to if somebody is a fast metabolizer, you may end up needing higher dosages or maybe comparable to methylphenidate, 40 milligram or 50 milligram to get the same benefit. So potency wise, you can keep in mind, but I won't utilize this information to convert somebody's on methylphenidate. Now let's transition to amphetamine salts. you were on this on methylphenidate, let's do 1/3 of the dose, 2/3 of the dose of methylphenidate. That's where we're going to start you on amphetamine. I always start from the lower dose, and I might turn the dose up quickly to get the benefit, but not utilize that as a base to make my decision on what dosage of the medication you should be putting the patient on. Some of the IR formulations, as I said, first is racemic amphetamine. This is like a Vicchio, which has D and L enantiomer 1:1. It's more amphetamine salt. And then we have dextroamphetamine, that is Gen-ZD. This is D amphetamine, which has only D enantiomer. And then there is also an oral solution of dextroamphetamine, that is Procentra. And then for IR formulation in methylphenidate, we have now solution of methylene solution and methylene chewable tablets, which have been there for a little while, but just something to keep in mind. And then Adderall salt is basically the Adderall that we use, immediate release or Adderall XR, which I haven't included because you all know of that, is more combination of amphetamine and dextroamphetamine together. But the formulation that you are seeing here is Vicchio is more amphetamine only, and Gen-ZD is more dextroamphetamine only.
Dr. Malhi, if I could just make one housekeeping note, we had a few members who joined in shortly after we began. Just a reminder that you will receive a copy of this slide deck. So these notations you'll have for reference. You don't have to take notes. And there are a few folks who are calling in by iPhone, and I can't see the moniker to identify who you are for our attendance. So if you don't mind, just please email me at mindy.webb@delaware.gov after the fact, so I can make sure that we get you this information as well. And Dr. Malhi, thank you for letting me share that note.
And then moving on to some of the longer acting formulations which have come up, like one of oral dissolving tablets. Contempla, which is XR-ODT, oral disintegrating tablets. That is the first oral disintegrating tablet of amphetamine and enantiomer, which is 30% immediate release and then 40% extended release microparticles. And same thing for oral disintegrating tablets for amphetamine salts is Argenis XR-ODT and Argenis ER, which is a solution. Yeah, and then in this combination, we have D and L enantiomer amphetamines, and we have 50% IR and 50% ER particles with the D and L enantiomers 3:1. So you may see that we have like D and L amphetamine as 3:1. Something to keep in mind that D enantiomer is slightly a little bit more potent than L enantiomer. But that doesn't, so what happened is when you combine them together, they take the benefit that combination works longer hours. So for example, D amphetamine plasma levels is like 5.6 hours. And then when it combined together, it can reach longer than that. So it's like combination has a longer duration compared to just a D enantiomer. That's why combining L enantiomer does not impact the functioning of D enantiomer in any way, but combination works longer hours.
Dr. Malhi, we do have a question in the chat regarding dosing. The question is, do you try to avoid twice-a-day dosing in young kids? For example, Focalin XR in young kids?
What would be the younger age we are talking about? Like young kids, like preschoolers?
And feel free to unmute Dr. Walter if we can hear you, or share the age range in chat.
Yes, can you hear me?
Yes, Dr. Walter.
I just wondering. I just never want a kid to go to the nurse at lunch, if at all possible, even in preschool. And I've been using I don't do it much, but even on 4, 5, 6-year-olds, since they can put it in pudding and stuff like that, using something like Focalin XR, generic. Just instead of using Ritalin.
So Focalin is dexmethylphenidate, which is basically the D enantiomer of the methylphenidate salt, which is which also has a good efficacy. So there is like, if we have seen that methylphenidate really works, even using the dexmethylphenidate, it's like elaboration, like extension of the outcome that we have already seen in preschooler study, right? So it's totally fine to utilize Focalin. I tend to just start with immediate release in the beginning, like for first 1 or 2 weeks, just to see that the kid is tolerating the medicine well. After once I have started it and they are tolerating the medicine well, I also usually tend to go to XR, so that to prevent the trips to the nursing station. But keep in mind that, as we know, that amphetamine salts or even the methylphenidate salts, metabolism could also be one of the factors. If somebody is a fast metabolizer, even if we utilize XR, it may not last for a whole day until they are in school until 3 o'clock. So there is a possibility that there are times when even doing XR, it only lasts for 3 to 4 hours, when actually industry information says that it should last for 8 to 10 hours. So there are times when I end up adding immediate release in the afternoon. But going to XR, if the kid is tolerating the medicine well, is a good practice in a way to prevent multiple dosing during the daytime.
Thank you.
Mm-hmm. So moving on to the next one, which is solutions and chewable for this one were more so for the oral disintegrating tablets for methylphenidate, and then Adgenis and Adgenis ER for chewable for oral disintegrating and solution. These are some of the equivalent XR that we utilize: 20% immediate release, 80% extended release particles. ER is the chewable tablet for Kulli Chew. Again, a little bit different than XR. It has like a little bit more, 30% immediate release, 70% ER. And then there is a Dynavel XR amphetamine solution also, which is 3:1 D and L enantiomer, which is basically another, other than the Adgenis solution that we utilize. This is another one, Dynavel XR extended release solution for amphetamine salt. So we do have now options available for solutions, oral disintegrating tablets, chewable tablets in both amphetamine and methylphenidate salt. So to concisely put it all together. So Vyvanse, it's a prodrug. It's a lisdexamphetamine. So it's basically the D enantiomer of the amphetamine salts. It's available in capsules and chewable. It's a D-amphetamine, as I said. The good thing about this is that it's a good thing also and a bad thing also. I can go over both the things. It is a prodrug and it does not get absorbed directly from the blood-brain barrier in the gut. It all the way goes into the small gut, where the pH of the small gut is basically act as a trigger for this medication to open up, and that's where it get converted into D-amphetamine and then get absorbed in the body. So good thing about this medicine is that if somebody is having, suppose a history of, like, if you are seeing any adult or any even teenager kid, like who has utilized any kind of addiction issues or substance use issues, so this could be one of the medication you can utilize, because it does not have any high feeling with the medication. Although the dosages we used for ADHD treatment any of them should not have any high feeling, because they are utilized only to treat the ADHD symptom, not like we are giving a higher dosages. But this medicine cannot be misused in any ways, because it does not have any street value also, because of the prodrug nature of the medication, how it gets absorbed in the system. So safety profile, tolerability, same as amphetamine salts. And another thing about this medicine is that there could be basically a window, like maybe it can a little bit longer than our amphetamine or methylphenidate salts that we utilize. They start working within 30 to 45 minutes. But because of the way the Vyvanse is absorbed in the system, all the way going to the small gut and then start showing the benefit, there could be a little bit longer window before really the medicine start working. So something to keep in mind, that the parent or the child says that, oh, I take the medicine at 7 o'clock, but I don't see the effect until like 9:30 or 10 o'clock, which could be true, especially in this case. So you may have to think about that. If that is the case, because everybody's metabolism is different. For some kids, it may not be a problem, but others may be. So to kind of keep those considerations in mind when you're making a clinical decision. And then we talk about the patch also, Datrona patch. You may have been aware of it. It's a methylphenidate patch. Duration is like 9 hours. Onset of action is also close to like 2 hours. Patch is applied for 9 hours. Should be applied on a clean, dry, unbroken skin. New site is picked every day. And it's like 50% immediate release and 50% extended release. One of the common side effects is dermatitis. And you can utilize like some of the common steroid creams, cortisone or something to kind of take care of that. We can make the parents aware of that. And then another thing is patch contains some of the patches can contain up to 80 milligram of methylphenidate. If somebody accidentally consume this medicine, it can be a medical emergency, considering how much it can just get absorbed. So making the parents aware of keeping it in a safe place is certainly one of the things we want to do.
I'm sorry, we do have an additional question in regard to variability of effects for brand versus generic.
Yes.
Types of Lisdex versus Vyvanse or Methiar versus Concerta. Can you speak to that?
Technically, there should not be effect, but if you talk about the reality, there are some times there is a efficacy difference, and that we can't know until the parent tell us. So I can this is more like probably I would say not literature-driven data I'm giving you. It's more like my own clinical experience that I have had. Like for example, Concerta. Brand name versus generic, big difference in efficacy. Even with sometimes I have seen a couple patients with Vyvanse also. Now we have Vyvanse generic also, and some difference in that medicine worked better than this. So I think you have to, this is more clinical information. We take it from the parents and then we advocate that yes, by law, there should not be any difference between what the brand was producing, what the generic is producing. But for some reason, some of these families are experiencing a difference in the efficacy when they are taking these medications. So that's something that have gone positively in some directions when the patient has tried multiple medications and the brand is the only one that works. Some of the insurance companies have approved it, but on other, if they only just tried Concerta in their life, and initially they were taking brand and now they switched to generic, and the insurance companies would say that no, you know what, you have to try 1, 2, 3, 4 before we even think about that. And then there is not much a counter argument there. And some of the parents who can afford it, they continue, they say that no, we are not ready to do it. We just going to go ahead and pay out of pocket, which is fine as long as they can afford. For other parents, unfortunately, then we have to run down the list and then get to where we probably wanted them to be on a brand. So I think it's just an unfortunate thing, but yes, that can happen and it's very real. So if somebody is saying that, I won't discard the information that can happen just because it should be same, but in reality, it can happen. And some of the other longer acting formulations that we have now is Myadis, that is a new one. So this is a more bead technology now that we are getting, in which there are multiple layers of beads that get released at different pH levels, which basically help us to get the long impact of the medications for long hours. For example, Myadis, which is amphetamine, salt, D and L, and enantiomer 3:1. It has a triple bead system, which basically some of the medicine get released as soon as you ingest it, and then some of the medicine get released at the pH of the proximal small intestine, and then the other one goes all the way down to small colon at pH of 7. That's where they get released. So this basically gives us like up to 16 hours of coverage. Then Apentensio, which is like 37% immediate release, remainder are like ER release, extended release can last. It's also multi-layer beads, can last up to 12 hours. And then Adhencia XR, again, 20 and 80 also multi-layer bead, last up to 16 hours. And so what do we, how, like, there's so many things are coming out. What's the point? The point basically now the focus is on novel delivery systems, such as either oral disintegrating, or we have seen chewable tablets, or we are creating liquids also now, patches. And then these novel beader technology where the medication can last for longer hours. So it's basically industries are creating now formulations that can give the best benefit to our patients. So I think some things to keep in handy with you, because some of these patients could be very, very fast metabolizers, and you want to avoid multiple dosing, and you can utilize some of these newer medications. Maybe that might give them a better coverage rather than 4 or 5 times dosage in a daytime. So that's the whole point of having all these newer formulations that we are seeing. And then we have a delayed release also, which is Jornay PM, which is methylphenidate salt, which is administered at like night time between 6:30 to 9:30. Basically, what it says is the medication kind of get released 8 to 10 hours before the drug begins to be released. So after a gap of 8 to 10 hours, medicine start working in the morning. One of the side effects could be that if you give this medicine sooner, it can cause like early morning awakenings. And then there is an extended benefit, is extended duration of action, things like that. So moving on to one of the other newer medication, those were all non-stimulants we talked about, that some of the newer versions, new formulations that have come on the market. And then there is another one, non-stimulant medication that have come up, is viloxazine. It is one of the medication, I think after years, and like more than after 2 decades, we have one newer non-stimulant ADHD treatment after Strattera. That has come up. Other non-stimulant treatments that we have before viloxazine were Strattera or guanfacine or clonidine, which have like all guanfacine and clonidine, which are more alpha agonists, and Strattera is norepinephrine reuptake inhibitor, and viloxazine is also same as Strattera as a non-epinephrine reuptake inhibitor, but it's an extended release capsule, which is slightly different from Strattera, in which in Strattera, we may end up doing sometime BID dosage also. Compared to viloxazine, we might need only single day dose. And it's proven treatment for children and adults, anybody 6 and above. Non-epinephrine reuptake inhibitor. Side effects could be just tiredness, headache, appetite can be affected, sometimes nausea, fatigue. And if you look at the study here, what they showed was it's like 104 subjects, close to 100 subjects. And this gray line is placebo line, which was not beneficial at the end of the 6 weeks. But blue line and this little bit of a yellow line there. Blue line is 200 milligram viloxazine, and the yellow is more 400 milligram viloxazine. What you see is that by week 5, 200 and 400 milligram were same, but at week 4, 200 milligram and 400 milligram has a better efficacy in reducing the symptoms of ADHD compared to 200, but over time it just became kind of like similar. But still, viloxazine 400 milligram was a little bit more beneficial compared to 200 milligram at week 6. But it was significant benefit. P-value was less than 0.05 to impact the ADHD symptoms. And then there are some other more non-invasive, like more newer treatments that are coming out. And one of them is TNS, which is trigeminal nerve stimulation. I think this is the study that came out in 2019. Basically, what it did was that they took like close to, I think somewhere between 60 to 70 subjects. Where they did was TNS nerve, it was given the TNS nerve stimulator was applied at night time every weekly for 4 weeks. And then it was thought that the trigeminal nerve stimulation is thought to stimulate the nucleus tractus solitarius, which relays signal to cortical and subcortical structures such as thalamus, hypothalamus, amygdala, locus coeruleus, RAS, anterior cingulate, and insula. And the treatment changes, what they observed, also made treatment-related changes in the resting EEG in the middle and right frontal region associated with improvement in hyperactive and impulsive symptom change. So there was a positive benefit with active and the sham treatment at week 4, applying this TNS nerve stimulator every night to help improve the ADHD symptoms. We do not have too much long-term data on TNS nerve stimulation. That it was only 4-week study. We haven't had much data come out after that. I have not prescribed this so far, but this is one of the other treatment options that has shown positive benefit for ADHD. So we don't know like how long we should continue this and what would be the long-term impact on the brain development. That is like something needs to be still figured out. And then we have another digital interventions also coming out. I don't know if you guys have heard about it or not. This was also close to 169 inexact like subjects that were recruited to see the outcome of digital intervention. So this was the study that was published in Lancet, I would say somewhere in 2020, if I'm not wrong. The reference is in the reference for the study you can see at the end in the reference slide. But it did was software treatment for actively reducing severity of ADHD. It's called STARS ADHD study. It was also randomized, double-blind, parallel group RCT of pediatric patients somewhere between 8 to 12 years of age. Digital interventions can significantly, but proposal was that digital interventions can significantly increase attention functioning of children with ADHD. And how they measured was digital intervention improved the cognitive performance, and the changes were associated with also measuring the outcome with EEG in the prefrontal cortex. And it's now FDA approved. And the app itself, and it's called Endeavor RX app. It's $30 per month for the app, and there are no long-term side effects with this this treatment. This treatment is prescribed in a way that treatment was given 5 days per week, that the kid play this video game for 25 minutes for 4 weeks, and it was measured in age group 8 to 12 years old. And it was randomized controlled trial, as I said before, and the outcome was measured by TOVA API, which is Test of Variable Attention Performance Index, from pre-intervention to post-intervention. And they see a benefit in the treatment after utilizing this app for 4 weeks. Side effects were like headache, mild frustration as the common side effect. So basically, this was the study I can show is... this is a nerve stimulation. Here it is. Was done by Colin SH and a novel digital intervention for actively reducing the severity of the pediatric ADHD. So you can look into the detail for this study, but we don't know the long-term impact of Endeavor RX treatment also. Like it's only done for a few weeks and it showed positive benefit. And then now Endeavor RX is like the industry is getting more data from different places to see the long-term benefit of this treatment. And so the cost, like the physicians can write a prescription and the patients can get paid through the HSA, like health saving accounts, to get this app, which can be prescribed app to treat the ADHD. So this was all for today, and I am going to stop sharing the slide at this point. If any questions, we can go over.
Please feel free to unmute yourself. Dr. Walter, go ahead.
Yes, I just wanted 2 things. One is just get your thoughts and your experience with both Journey and also this new, I guess the brand name is Kelbry, since the data looks really good. It's a non-stimulant, and and each of them how you would dose them.
So Quellbri I have utilized in a 6-year-old also. We failed all the stimulant treatments. Patient was like having so many side effects with each ADHD medication, stimulant treatment, like significant weight loss, irritability. We did try Quellbri. Started with 100 milligram, went up to 200. Right now, patient is only on 200. We didn't have to go up beyond that. The only side effect we got was a little bit of sedation in the beginning, but very well tolerated. Didn't have any challenges. Other patient that I tried with was autism with ADHD. Again, all the same difficulties. Poor response to stimulant, couldn't tolerate any of the stimulant treatments. We tried even guanifacine also, then tried Quellbri, caused excessive sedation, so that we had to stop the Quellbri, and he's tolerating instead Statera better, which is, I don't know what's the reason for that. But yes, it is an effective medication, and I would say that give it a shot, considering that you don't have to do multiple dosing, being it an extended release. Journey, I have done in kids, especially where their parents consistently complain about morning challenges. Morning challenges, you will hear that complaint from majority of the parents because the medication take a little bit of time in the morning to begin with. But some patients where there is a significant disruption in the morning, irritability, that everything is done and we are not able to get control. So I have couple patients now that are significantly better in the mornings with the Journey that's prescribed at nighttime. The only challenge is that even in those patients, I have to do extra dosage, like around 2 o'clock or 3 o'clock of another methylphenidate, because the impact of the medicine, even if it's said lasting about 12 to 14 hours, doesn't last that long. So that's the only thing that keep in mind, that benefit might not be sufficient for the whole day, especially for significant behavior problem kids.
Thank you.
Mm-hmm. Yeah.
Another one? If no one's asking.
Yes.
Just any of your tricks on when you start the medications and you're trying to start low, go slow, go up. I sometimes will give 30 pills and then say do 5 for 5 days, and then do 2 pills for 5 days, 3 pills. Do you give multiple scripts for 1 week at a time? Just the nitty gritty of
yes,
how you do it.
I think I try to do 2 weeks. Suppose I'm starting 2.5 milligram methylphenidate for a 5-year-old. Then I would say that, okay, let's do 2.5 milligram for a week. If you think that it's working well, we don't need to go up, just continue 2.5 milligram. But after 1 week, if you see that the kid is still having difficulties, because stimulants effect is obvious very quickly, then go up to 5 milligram. And I usually do a phone call after that, within 2 weeks. Hey, give me a call, see how you are doing. Because sometimes these parents may not be as sophisticated to follow the instructions, and other parents could be very much. They stay on top of everything. So I do a quick phone check. Hey, how things are going? If we need to bump the dose in between, or okay, let's go to 7.5 milligram. I'll send you another prescription and see you back in 2 weeks. Something like that. Do check in within 2 weeks, because something just to make sure that I'm not missing anything, and it's a right choice to go up on the dose beyond that, especially with the younger population. With the older population, I can still be a little bit more flexible, letting the parent decide on that, especially if a kid is 80 kg, right? And I know that this kid is going to need a higher dose based on the weight based. So if I'm starting on 18 milligram Concerta, I give them the option, hey, after 18 milligram, I'm given another prescription right now, go to 27 milligram and then 36 milligrams. So it all depends on how much comfort you have with the family. There is no hard and fixed rule on that. I think one of the challenge with ADHD population is a comorbid condition. You never gonna get very rarely get plain ADHD. So making sure that the comorbid conditions are addressed that's when you can see the full benefit of these medications. And secondly is some of the sensitivities that we see with the neurodevelopmental population, especially ADHD utilization in autism patients or in intellectual disability patients, could be something to keep in mind, even if it's an older kid, to start low and go slow. So they certainly are very more sensitive to the side effects compared to the neurotypical population.
Dr. Malhi, can you speak just for 1 minute about, the differences in an ADHD diagnosis for a child who has inattentive hyperactive type versus a child who has inattentive disorganized type? That the presentation may not be one and the same for different children. So how to address the medication management based on the presentation of the symptoms.
What would be inattentive disorganized type?
My own child diagnosed inattentive disorganized, so he's not hyperactive, but he has trouble keeping track of assignments, paperwork, due dates. His issues and related to something like a 504 IEP are really not more about, it's more about getting himself collected and being able to attend to tasks as opposed to a hyperactive presentation. He's not bouncing off the walls, things of that nature.
So one thing I would clarify the terminology is it's ADHD inattentive type, ADHD hyperactive type, and ADHD combined type. There is no ADHD disorganized type. So basically disorganized type is ADHD, I'm assuming inattentive type. Where there is a more challenge with hyperactivity, executive functioning compared to not so much of hyperactivity symptoms, which we normally see as usually the hyperactivity symptom that is commonly seen in boys in younger age group kind of mellows out as they grow developmentally over time. And then that like symptom usually kind of like goes away, which is also one of the reasons that we may have like more male and female equal gender presentation in adults compared to in children, where many of the ADHD inattentive type in the girls might be missed because you don't see that hyperactivity in girls. Yeah, so I would say that is more so what you are saying is more ADHD inattentive type, which certainly requires the same level of attention compared to inattentive hyperactivity type, because ADHD inattentive type is probably one of the, as I said, like underdiagnosed and can lead to more emotional problems later on in life, such as if we don't pay attention to such a disorder in our young population can lead to more self-esteem issues, difficulties with emotional regulation, feeling more sad, depressed, or how I am different from other kids, why can't I do the same amount of work as others, and more like depression, anxiety, those type of symptoms. Whereas hyperactive type kids get easily picked and may get more attention because of their behavioral disturbances, and might benefit from that by families or school kind of being more proactive to support those kids compared to the inattentive type, where we may end up not getting as many services in schools also, and also less contact with the medical providers as well.
Great, thank you so much. I know we are at the end of our time. Can I ask?
Thank you.
Thank you. The two folks who are on iPhone, again, please either state your names now or email me with your contact details so I can share the slide deck with you later today. I do want to thank Dr. Malhi, you for your time, for your expertise, for sharing this information in such a palatable and useful way. I think this is going to really help medication manage, skill building for our providers. And, again, this is not a one and done. If folks have questions about ADHD medication management treatment or other issues, consultation services continue to be available with DCPAP. So please do just contact us. Any last questions for Dr. Malhi or any last notes from the folks online? No. iPhone participants, can you state your name?
Aline Alorto?
Thanks, Aline. Anybody calling in from iPhone? I see iPhone 73, iPhone 142. Hopefully I'll catch them in post. Thank you again, Dr. Malhi, for your time. Thank you, everyone, for joining us this early morning presentation time, and I wish you all a great rest of the day.
Thank you so much, Camilla.
And look for my email.
Have a good day.
Thank you. Be well, all.
Thank you.
Bye.
Happy holidays.
Thank you, and happy holidays to you all as well.
Thank you.